Good evening. Welcome to our lecture on recognizing and treating heart failure. Before we begin, I need to make a few announcements. At a time when we're all asked to limit our trips outside our homes, a visit to the doctor may seem out of the question, but if you have a new or ongoing health condition or develop a medical emergency, it's critical to get treatment right away, even during this pandemic. Boulder Community Health staff and facilities are prepared to treat a comprehensive range of medical issues while keeping patients protected from the COVID-19 virus. Doctor visits are available both in person and through virtual visits. And emergency responders and emergency department staff know how to keep you safe from the threat of COVID-19. Now I'd like to go over our format for the lecture. The lecture portion will last about 45 minutes. Afterwards, we'll use the remaining time for questions. Please type a short question in the chat box to the right of your screen, and we'll do our best to get it if time allows. On behalf of Boulder Community Health, I'd like to introduce our speaker, Dr. Scott Blois of Boulder Heart. Thank you.
Thank you. Well, if it's okay, I'm going to take my mask off. Please do be safe. We're in an auditorium right now. We want to keep Boulder educated. There's only 3 of us, and I can see nobody within about 50 feet of me. So if it's okay, my glasses would steam up if I tried to do this lecture with a mask on. First, I just want to say thank you for tuning in, and we're all a community here in Boulder, and I wish everybody the best and good health. What I'd like to talk today about is maybe something a little bit different than COVID-19, though I do have a couple slides in it that will talk about it with heart failure. But I'm a cardiologist over at Boulder Heart, and this is a little bit about me. I was born and raised in Northern California. I went to college at UCLA, and I did my medical school training down in Houston at Baylor College of Medicine, which had Dr. DeBakey, one of the leaders in heart surgery. This is sort of my second time up in Colorado. I did my residency for about 7 or 8 years and fellowship in the 90s. And then I moved down to Austin, Texas and ran a heart failure transplant clinic down there. I thought Boulder Heart and Boulder Community Health were very progressive in wanting to start the first heart failure clinic here in the Boulder County and invited me to join the staff about 4 years ago. And really, in the last 4 to 5 years, we at Boulder Heart have 12 cardiologists. We've grown our heart failure clinic to about 700 patients. We, as we're going to talk about what a heart failure clinic does, really try to emphasize co-management with patients who suffer from chronic congestive heart failure, do a lot of education, but have access to state-of-the-art medicine and devices. What I'd like to do for the next 45 minutes is follow this outline. Try to give you a definition of heart failure. Tell you and try to convince you that unfortunately it's a very common disease process that's continuing to get more prevalent in the United States. Talk a little bit about the signs and symptoms of heart failure and then some of the causes of heart failure. We're going to talk about maybe if you suspect that you might have heart failure, what are some of the tests that we would do to rule it in or confirm it. And then briefly hear about treatments of heart failure, both medicines, pacemakers, defibrillators, and then talk a little bit about some of the lifestyle changes that need to occur to successfully be able to treat heart failure, and leave 10 to 15 minutes for questions. So if you looked in a textbook of cardiology, a definition of heart failure might be a clinical syndrome which ensues when the heart is not strong enough to pump blood to meet the metabolic needs of the body. This slide here sort of shows the main 4 chambers of the heart. And as you can see, the bottom 2 chambers are called the ventricles. Those are sort of the pumping chambers of the heart. And when we talk about heart failure, mostly we're talking about diseases that affect that left ventricle there. Unfortunately, heart failure is pretty common. About 1 in 5 people will develop heart failure in the United States during their lifetime. There are probably about 5 million cases of people with symptomatic heart failure, and there's probably another 5 to 6 million people walking around with asymptomatic weakening of their heart that need to get this diagnosed and get on medicines to help the heart get stronger. There are about 500,000 cases of heart failure new each year, and unfortunately, even now in 2020, with all the advances we've had, there's still about 250,000 people a year that die of congestive heart failure. It's a costly disease. This is mostly bad, but also good. A lot of research comes into this, but in 1998, America spent about $20 billion on heart failure. In 2014, we had spent $32 billion, and this is people from hospitalizations to the medicine we use, to the doctor visits, to home care, the whole package. And it's estimated that in 2030, it'll be up to $72 billion. It's the most costly heart disease in the United States. If you combine treatment of heart attacks, bypasses, and stents all together, it's still more than all those three. And for example, the average length of stay for a person who gets admitted with heart failure, and I'll go through in a couple minutes that a lot of times water can build up in the lungs with trouble breathing. It's usually for about 5 days in the hospital, and that costs about $30,000 to $40,000. And some people with advanced heart failure can be in the hospital up to 4 or 5 times in a year. So we're talking $150,000 just for that. This slide shows just another confirming the prevalence and the growing of congestive heart failure, and that really it's a disease that is going to be becoming more common as we age. So what are some of the symptoms of heart failure? I like to think of the acronym FACES. And for example, people with congestive heart failure will get fatigue. Their heart's not pumping well, so it's not getting good blood flow out to your muscles and to your lungs, and so activities are often limited. The heart is not pumping well, and blood and fluid can start to accumulate in different organs in your body, including your lungs, so you can get chest congestion. You can get swelling and edema in your ankles, and then lastly, shortness of breath. So FACES, F-A-C-E-S, is with those symptoms is some of the things that I think of. It's important to think of congestive heart failure. Now, if you had 100 people come into the emergency room with tiredness or shortness of breath, heart failure wouldn't be the leading diagnosis. There are other things, a cough, asthma, anxiety, depression. But if you're not getting better, then you should think about congestive heart failure. For example, I probably see 6 patients a year who get treated for asthma with inhalers or steroids, or pneumonia with antibiotics, or an upper respiratory infection, and they just don't get better. And then eventually their doctor or nurse practitioner says, maybe this could be related to the heart, and it really is congestive heart failure. Also, depression and tiredness in an elderly person can sometimes be a sign that the heart's not working well. So what are the leading causes of congestive heart failure? Probably the number 1 and 2, they alternate, is coronary artery disease, having a heart attack, cholesterol blockages in your heart, or uncontrolled high blood pressure. This isn't one blood pressure reading, but it's a person who maybe goes to their dentist, and the dentist says, your blood pressure is 180 over 110, you ought to get that looked at. And it's sort of forgotten, and that goes on for 2 or 3 years. That will cause the heart to weaken. So coronary artery disease and uncontrolled high blood pressure for months to years are the 2 leading causes why people have their heart get weakened. The third most common in the United States is called an idiopathic or double hit theory. And idiopathic is a fancy word for we're not really sure. But we think it's probably a combination of a virus affecting the heart plus having a genetic predisposition to that. So somebody else in the family has had early congestive heart failure in their 30s, 40s, or 50s, and somebody gets a respiratory illness, which for most people it would just affect your throat or your lungs, but this virus and the person has a predisposition to it hurting the heart. The fourth and fifth is valve problems, both either they start to leak or they become stenotic. And then we know if you're using more than probably 1.5 to 2 alcoholic drinks a day, it turns into a toxin to your heart. So alcohol-induced heart failure is relatively common too. This is a big table just talking about all of the 30 or 40 different things that can cause congestive heart failure. And one of the things at our clinic will be to make sure you're not having one of these rare things. For example, besides toxins, we mentioned alcohol, but lead, unfortunately, using cocaine repeatedly can hurt the heart. And metabolic things can do that, thyroid, endocrine. And then infection process from bacteria. Coronavirus has affected usually only in about 10 to 20% of people that have the virus can affect the heart. But many different inflammatory things can do it, lupus, rheumatoid arthritis. And then lastly, genetic things like neuromuscular disease and Duchenne's. So all these things can do that. So if we think, or you thought maybe, I have some symptoms that I'm concerned could be congestive heart failure, what would be some of the testing we would do? Well, we would start with sort of very non-invasive, inexpensive things to do. And for example, an EKG is very helpful. If the heart has gotten weakened, a lot of times what happens, it starts to get enlarged. Or if we think coronary artery disease is one of the main reasons why the heart could get weakened, we can sometimes see a heart attack occurring or have occurred on an EKG. So an EKG is a very good first step. Some labs are also very helpful. We look to see if you're anemic. We look at your kidney function, your liver, your thyroid function. A chest x-ray is helpful, partly because when the heart gets weakened, it gets enlarged. It's not pumping enough blood from that left ventricle, so it gets bigger. So on a chest x-ray, we can see an enlarged heart. And also, as we talked about, a person with congestive heart failure is at risk of having fluid building up in the lungs. A chest x-ray can tell us if there's any water building up in the lungs. Lastly, an echocardiogram, which I have another slide going to go over that, is a very important test and probably one of the most important tests if you think you might have congestive heart failure. And then there's a new lab that got developed in the last 15 years, which is very helpful, called a brain natriuretic peptide level. So this is what an echocardiogram looks like. It's the same equipment that when a woman's pregnant, they do an ultrasound of the developing baby or an ultrasound of your liver or spleen. But we can do an ultrasound of the heart, and you can see sort of that heart beating in the top picture, and we can see the heart muscle pumping, we can see the valves opening, and it really tells us how the strength of the heart is doing. A brain natriuretic peptide, and it's called a BNP level, is a little bit misleading because it says brain, but it has all to do with the heart. This is a protein that's made in the heart, and it's in the walls of the heart, and if the heart gets stretched out or dilated or weakened, it's released into the bloodstream, and we can measure that with a blood test. So the best thing to do would be to have very little of this protein in your bloodstream. If it's really elevated high, that can be a sign of congestive heart failure. So it's a very important lab test that's done, especially in the emergency room, to evaluate a person who's short of breath. What we typically do is draw that, and if the level is above 450, that's concerning that shortness of breath can be coming from congestive heart failure. If it's around 10 or 20, as you can see from the slide, there's really only about a 1 to 2% chance that this is coming from heart problems. So if you're short of breath, a lot of times getting a BNP level will be helpful. Just as helpful to rule it out as to rule it in. Going from sort of invasive or non-invasive and less expensive to more invasive tests, one is a heart catheterization called a coronary angiogram. If we think that maybe the heart is weakened or it has become weakened, there's a good strong possibility that cholesterol problems can be involved. So we a lot of times will do a heart catheterization. And if there's a blockage, open up a stent. An MRI of the heart is helpful many times, especially if we think there's sort of an autoimmune process where the body is attacking the heart. A lot of times we can see a certain pattern on the MRI. A stress test, a lot of times we're looking to see if there's cholesterol problems. And then labs, and then rarely genetic testing. When I say rarely, about 20 to 30% of the time. That's a developing field. We can draw blood and sort of look at different genetic abnormalities, but it's not something we do straight on everybody, maybe at about 20 to 30% of the time. So we've done the testing and we've confirmed that a person has weakening of the heart, congestive heart failure. It's then important to figure out how severe it is. And there's two main classification symptoms out there that we look at. One of them is called the New York Heart Association's class symptoms. And that was really developed in the 70s, 40 to 50 years ago, but it's still a very important prognostic classification. So there's class 1, 2, 3, and 4. 1 is the least severe, 4 is the most. So class 1 is somebody who we have some testing that shows that the heart is weakened and in failure, but there's no symptoms at all. You talk to that person, they can hike up Mount Everest without getting short of breath. But we know on a test that the heart is weakened, and that's important because things are starting to go on in the body that are bad. But that's class 1. A class 2 heart failure patient is somebody who's got some testing showing the heart's weakened, and they do get short of breath, but with really a lot of exercise. So they go a mile and then they start to get short of breath. Class 3 is somebody who really mild exercise, walking only 1 or 2 blocks, can get them short of breath. And then class 4 is somebody who has heart weakening on an objective test with really they're short of breath at rest. So I think about in my lobby at Boulder Heart, we bring you in and walk you down a hallway about 100 feet. The person who gets short of breath walking down that hallway to my office to see me is really a class 3 heart failure patient, and that's a serious problem, as you'll see in a second. There's a new classification system that came out in the last 10 years, and this really was that we found that people at risk of heart failure, the damage has not occurred yet, but are at risk, are important to know about too. And that's the class A person. These are the high risk for heart failure. And this is somebody who maybe has high blood pressure, but on the echo there's no damage to the heart, or they have coronary artery disease, actually diabetes, or they have a strong family history of many members at a young age developing heart failure. Class B is sort of the equivalent of the class 2, C is a 3, and the D is the 4. Why do I belabor all this? Well, this is sort of probably my most somber slide of the 45 minutes. We know that if you have class A or a class 1, your 1-year mortality is about 2 to 5%. That's higher than if you don't have heart problems. And the chance of being hospitalized is about 1 in 400. But as you start to have symptoms, like that person who gets short of breath walking about 6 or 7 blocks, there's about a 5 to 15% mortality a year. And then that person who has trouble walking down the hallway to my clinic is a class C, and that is about 15 to 20%. And then really that person who's short of breath just talking has some significant risk of having heart problems in the year. And I think explaining this to the patient, not to ruin the hope, but to really say this is something serious, and something serious could happen in the next months to years if we don't get on the right treatment, really helps in buying into the treatment and compliance, and also for a person to plan out their future. Also, for those 5 million, 6 million people that are walking around in the United States with congestive heart failure right now, they are more at risk for bad things happening if they get the COVID infection. So, for example, we know that right now from the studies out of countries that have had more COVID maybe 2 or 3 months before us, that it's about a 1% chance mortality of dying if you have no health problems. But the person, unfortunately, that has congestive heart failure, even if they're on the right meds, the risk of dying is about 10%, so 1 in 10. So usually if we had an audience full of people or live streaming, we'd all take a deep breath right now and say, okay, that's the bad news. But one of the reasons that I'm so enthusiastic about being a congestive heart failure expert is there has been a lot of improvement in the last 30 years and a lot of good news. Really, before 1990, if you developed heart failure, we could treat you with diuretics, things like Lasix to get the fluid out of your lungs or the fluid out of your legs. We could use digoxin, which had been around for years. And actually, morphine is a very good medicine to treat because it seems to dilate the veins and the lymphatics in your lungs and help get rid of some of that fluid. But unless you really went on and got a transplant, the chance of dying in 5 years with congestive heart failure before 1990 was as bad as having metastatic lung or breast cancer. But starting in the early 1990s, which happened to coincide with my training time, what they found was that when the heart gets weakened, you turn on about 3 to 4 hormones in your body, which seem to sort of whip the heart to keep working. And one of the real things that you want to do is block those hormones and give a heart some time to recover. And this sort of became the covenant of heart failure, and it became a much more treatable, benign disease. So in this slide, it's a busy one, but on the top, you have something that hurts the heart, a myocardial infarct. This leads to that box right here, and I'll show it right there if it comes across, is activation. You activate adrenaline in your body. You activate what's called renin-angiotensin, which is this hormone that comes from your kidneys and adrenal glands. You activate inflammatory things that come from your blood vessels. And all those things have been shown to be bad for the heart and make it get weaker. And so a lot of the medicines that we've developed block right here on this pathway from this box full of all these hormones activating to making the heart get weaker. So what are some of the medicines we've used in heart failure? One of them is called beta blockers. And usually now, if we had an audience of 100 people, I'd ask how many people are on a beta blocker, and probably about 20 people would raise their hand. The beta blockers are really helpful in blocking the adrenaline level that's activated in somebody that has heart failure. We know that if you have a damaged heart and we took a vial of your blood, your adrenaline level is about 8 to 10 times as high as normal. And the two main beta blockers that have been shown to block this adrenaline surge and give the heart time to recover have been carvedilol and metoprolol in the United States. The other hormone that seems to be activated is this one called the renin-angiotensin system, and the ACE inhibitors and the ARB angiotensin receptor blockers seem to block those well. And then lastly, aldosterone blockers are actually a diuretic, but they also seem to block these hormone surges. So the big key message is there's been medicines found to block the hormone surge that the body does when the heart's been injured and seems to help. This table just shows some of the early heart failure studies with ACE inhibitors and beta blockers in the early 90s. And if you basically took an ACE inhibitor, your chance of dying or decreased by 16% in the first year. And if you took a beta blocker, it went down 36%. And if you took those two medicines together, in 1 year, you decreased your risk of dying of heart failure by about 50%. And this was remarkable. And now, for example, when they do studies with heart failure patients, they're all on an ACE inhibitor or a beta blocker. It wouldn't be ethical to not have them on that for systolic heart failure. And it's not only being on the medicine, but it's also the right dose. The more of the medicine you take, the better chance the heart's going to do well. So for example, with carvedilol, this was from 1996, about 24 years ago. If you took a little bit of it, you got a little better. But if you took up to 25 milligrams twice a day, it helped even more, and the risk of hospitalizations went down. So it's not only being on the right medicines, but it's also being on the right dose. One thing that's come out with the COVID infection, and it was sort of initially thought of theoretically, but then it's been shown to not be true, is using ACE inhibitors and angiotensin receptor blockers during our COVID pandemic. And that's because there was some initial concern that using this in heart failure patients or people who take this for high blood pressure would increase the risk of getting a COVID infection. And what researchers researching the COVID pandemic found was that the COVID virus attaches to the ACE2 receptor and gains entry into the cell with that. ACE inhibitors and ARBs upregulate this ACE2 receptor, so you have more of it on the cell. So they thought it was more of an opportunity for the virus to get in. When they really looked at that, these medicines are so important in keeping the heart strong that people who stopped this actually had a worse result. So even though there's a theoretical risk, what has been found is you should definitely not stop your ACE inhibitor or angiotensin receptor blocker during the pandemic. Other sort of less important medicines to use, diuretics. We talked about that a person with heart weakening, congestive heart failure is at risk of fluid building up in the lungs. So we use a lot of diuretics to help get the fluid and the salt out of your body. And this helps control the symptoms of congestion and swelling in the legs. And the main diuretics we use are Lasix, which is also called furosemide, Demodex, or hydrochlorothiazide. Digoxin, though I mentioned was very common to use before 1990, is really rarely used now, and that's just because it's got a very narrow therapeutic window, and a lot of people can get toxicities with that. So unless you really have atrial fibrillation and heart failure, we probably only use digoxin now about 20% of the time. Hydralazine isodil is a combination that has been shown to help, especially in the African American population with heart failure. Supplements, many people are interested, have supplements been studied in heart failure and is it helpful? Unfortunately, the answer is not that helpful. Omega-3 fatty acids have been helpful. This seems to work, especially if you've had a lot of cholesterol problems and preventing further heart attacks, and actually some data on dementia. Coenzyme Q10 is a helpful medicine to help mitigate the side effects and toxicities of statins. A multivitamin every day is helpful. And if you're anemic, taking iron is helpful. If you're not anemic, iron was not shown to be helpful. But unfortunately, all the rest of the multivitamins or supplements that have been studied have been to show, at best, have no effect and sometimes to be harmful. The top paragraph here mentions a new drug called Entresto, which is an exciting new breakthrough that's occurred in the last 2 to 3 years. And this basically is another hormonal blocker that seems to help block this hormone surge and help with heart failure. As we talked about, the muscle of the heart gets weakened, but the electrical system can get weakened also. And with that, a lot of times either the electrical system goes too slow or becomes very disarrayed and can go too fast. So a lot of people with congestive heart failure need to have a pacemaker too. And there are times, especially if the heart is weakened to the point where we sort of look on the echo that it can't pump out 35% of the blood, that's called the ejection fraction, or you're having dangerous arrhythmias from the bottom of the heart called ventricular arrhythmias, a defibrillator is sometimes used also. I don't want to go too much into some of these, but also just to say that one of the big breakthroughs that's happened is now we do have mechanical hearts where we can actually surgically put them in and it can take over the function of the heart. This is called a ventricular assist device and really has remarkably improved. The first one was in the 70s and it was about the size of a refrigerator, and now they can put one in that basically can be in the palm of your hand and can last for 3 to 5 years, the bearings helping with the heart. If this needs to be done, we usually send you down to the medical school, which has a ventricular assist device program. But for sort of that 2 to 5% of very, very sick people that the medicines don't respond, this is an option. And then also heart transplants can be helpful in certain people. Usually that's a person under the age of 65 or 70 disease, or 65 or 70 years old who doesn't have a lot of other disease. But as you can sort of see here, the first transplant was actually in a kidney in 1947. Denver was famous. We had the first liver transplant in 1963. But in 1967 and 68, heart transplants started. The first heart-lung transplant was in 1970. But the real breakthrough was when they discovered a drug called cyclosporin that really helped people not reject their heart in 1981. And transplant cardiology really took off then. And now actually we have about 20 to 25,000 living heart transplants in the United States. And it's not perfect. but a 1-year survival of about 85 to 90%, and a 5-year survival of about 65%. So the ventricular assist device and heart transplants are a safety net for a lot of people, but the good news is the medicines are so good that a lot of times we can stop the heart from getting weaker and actually help the heart get stronger. This is an organ that can regenerate. So we've talked a lot about the medicines and the defibrillators and the surgeries that we can do, but you can be doing all of those things, and if you have a weakened heart, you can still be having a lot of symptoms if you're not following the certain lifestyle modifications. And one of the things that we talk about and really educate and spend some time on at the Boulder Congestive Heart Failure Clinic is going through some lifestyle modifications that you need to do if you're living with congestive heart failure. And one is a lot of patient education. We talk about what a normal blood pressure is for a person who has heart weakening. It's a lot different than somebody who doesn't have heart weakening. A normal blood pressure for somebody with no congestive heart failure, we want that top number about 110 to 145. That would actually be downright hypertensive for a person with heart failure. And a normal blood pressure for a heart failure patient, that top number might be about 95 to 120. And with that, you're walking around feeling fine. Fluid and salt restrictions. We're going to go through that in another slide a little bit. Also talking about, like we've done for the first 30 minutes, the pathophysiology of heart failure. What happens when your heart gets weakened? These hormones that are activated. Why we have to take multiple medicines to block the hormones rather than a single silver bullet medicine really helps to buy into the heart failure treatment and unfortunately adhere to a polypharmacy and rather complex medicines to take. Non-steroidals we're going to talk about in a second. Motrin, Aleve are great pain medicines but are actually dangerous in somebody with heart failure. Minimizing alcohol consumption, as we talked about, alcohol can injure the heart. Looking for cholesterol blockages and blood flow problems. Getting on blood thinners to prevent strokes. And then talking about immunizations and things like that we're going to go through. So immunizations are an important thing in heart failure, and we're sort of seeing that in the COVID pandemic. We know that you've got an injured heart. When you get stressed from an infection, whether it's COVID-19 or influenza, non-COVID-19 or pneumonia, your body is put under a lot of stress. And if you've got a weakened heart, there's more of a chance that your body's not going to be able to tolerate the stress. So we really work hard on immunizing our patients for the yearly flu and for pneumococcus, the flu. And that's been shown, for example, in this study where during the months of sort of November to March in this study in Scotland was when the spike of people dying of heart failure occurred. And when they looked into it, it was because of all the respiratory illnesses. So one of the really important things is to keep up with your immunizations if you're living with chronic congestive heart failure. Obesity is important. One, in that it can be a risk factor for developing heart failure, and then if you remain obese while you have congestive heart failure, it's not a good thing. There is a suburb near Boston called Framingham, Massachusetts, where everybody goes to the same hospital. All the medical records seem to be in one hospital center, and a lot of epidemiology studies have been done from Framingham, Massachusetts. And what they found when they looked at this retroactively is if you're obese, your risk of developing heart failure is higher. And so, for example, when they look at body mass index, which is a marker of how we measure, if you're sort of 5% above what is considered, if you're 1% above your BMI, the recommended BMI, you have about a 5% increased chance of developing heart failure if you're a man. And if you're 1% above your recommended BMI, it's a 7% for women. So really, when you start to get 10, 15 percentage points above your BMI, your risk of heart failure goes up dramatically. Non-steroidals. We know that non-steroidals affect how your blood flows in your heart. So they looked at it, and people who took non-steroidals on a daily basis actually had a worse chance of dying than not. And it now is recommended not to take nonsteroidals if you have heart failure. And as this study shows, about a 10-fold increase in dying if you take nonsteroidals on a regular basis. Does that mean you could never take another nonsteroidal if you have a heart failure? No. If you're a person who gets just horrible gout and you need to take Motrin for 3 or 4 days to get over a gout attack, that's probably okay. But it's that person who takes Motrin or Aleve or Indocin daily for chronic pain problems, you are bringing up your risk of dying if you have congestive heart failure. Salt and water restrictions. We talked about that this pumping chamber, the left ventricle, is weakened. And so if you're eating a lot of salt, the way your body transports salt is it puts a water molecule on that. Or if you drink 5 glasses of iced tea for lunch, it's just too much for the body to absorb from the stomach into the veins and pass through the heart out to the kidneys. So one of the things that we talk about with our heart failure patients in clinic when we're first getting to know them is you really have to restrict how much free water and salt you drink and eat, or you're going to start to fill up fluid in your lungs. And what we talk about is usually 64 ounces of total fluid. And that's your coffee, that's your milk and your cereal, that's your water. So about 6 to 8 glasses of total fluid in a day is what we recommend. If you're up around 15 to 20 glasses of fluid, it's going to just be really hard to mobilize that out to your kidneys and urinate it out. And then also about smoking and alcohol in heart failure are big things we really talk about. And for example, we said that probably one of the top 2 reasons why people develop heart failure is cholesterol problems and having a heart attack. We know that if you've got heart blockages from cholesterol and you're smoking, you raise the risk of having another heart attack by about 8-fold. And so we really talk about getting off the cigarettes to protect the muscle that hasn't been damaged from heart attack. And then I have patients in clinic who go, Dr. Blois, I don't believe you anymore. You said that if I took all these medicines, the beta blocker, the ACE inhibitor, things like that, there was a great chance my heart's going to get stronger, and we just did another echo and it's not getting stronger. How come? And unfortunately, about 20% of people that doesn't get stronger, majority do. But a lot of times I'll say, are you still drinking 4 glasses of wine a day? And they say yes. And so that is a negative factor in the heart. So if you keep on drinking a lot of alcohol, all the medicines we use are not going to be that helpful. People are asked about exercise in heart failure. Do I need to go, I've got an injured heart, should I go sit on the couch and do nothing? And the answer is no. You can go out and exercise. It's been well studied and actually it's good for you. Moderate exercise in congestive heart failure has been shown to decrease your chance of being rehospitalized with heart problems or dying from heart failure. And when they studied it was sort of moderate, what your brain and your body says is moderate, for 30 to 35 minutes, 4 to 5 times a week. And it was such dramatic results that Medicare and CMS and a lot of insurance companies will pay for you to participate or cover, not pay you, but cover the costs to do outpatient cardiac rehab for 2 to 3 months after you have been diagnosed with heart failure, because exercise is so important in a good way. And then lastly, understanding polypharmacy, I think, is important in treating heart failure. As we said, a lot of things are going on, and luckily from 1991 to now, for the last 30 years, we've made significant improvements where now it's not a death sentence, but actually a disease that you can live with chronically and have a very active, relatively symptom-free life, especially if you catch it early. But you've got to take some medicines, and unfortunately it's just not one medicine, it's usually 4 to 7 medicines. So one of the things we talk about is we re-emphasize these hormones that are activated in heart failure, that there are 3 or 4 hormone systems that are activated. We haven't found one magic bullet that can block all those hormones, and that really you're going to need to take 4 to 7 medicines to best treat your heart failure. The good news is probably 95% of those medicines are generic, so they're $4 to $10 a prescription. And this helps them really learn to take their medicines. And then also, we think of as your daily weight when you wake up in the morning after you've gone to the bathroom as almost one of your vital signs, like your pulse or your temperature or your blood pressure. And we really talk with our congestive heart failure patients about meticulously getting a good scale and watching their weight. And if their weight goes up 3 to 5 pounds in a day, that's usually a warning sign that fluid's starting to build up in their body. So, last one is heart failure clinics. And there's been a lot of study about heart failure clinics. And what they found is really going to a heart failure clinic increases your chance of surviving and not being hospitalized and living better with congestive heart failure. You get on the best heart failure medicines, but as that slide that showed about carvedilol and beta blockers, it's not only getting on the right medicine, but getting on the right dose. So some people will go see somebody get put on 3 milligrams of the medicine when really if they take 6, 9, or 25 milligrams of that medicine, they'll do even better. And heart failure clinics in general know the literature, know this, and will get you on the right dose. There's been many studies that show better survival, less chance of getting hospitalized with heart failure. It's more cost effective, both for the patient when they're deductibles, and also for the insurance companies. So a lot of insurance companies will ask you to go to a designated heart failure clinic. Also, I think you become educated on your disease better. You understand it better because we take time teaching you about congestive heart failure. Most heart failure clinics, we do a lot on the phone with our nurses. So we have staff built in that can answer phone calls, and a lot of times we can make adjustments in your diuretic or something to avoid having to go to the ER. And actually, outcomes at Boulder Hospital, our Foothills campus, the Medicare CMS tracks how you take care of your congestive heart failure patients. Not only do you survive the hospitalization, but how you do for the next month to 6 months to a year later. And Foothills Hospital is considered one of the best in Colorado, and actually our statistics are better than the national norm in heart failure. So the last 2 or 3 slides that I have, because I think we're getting close to being done, future breakthroughs. Genomic testing. One of the things that we're starting to see is maybe, and it's all personalized medicine, maybe based on the genes you have, certain medicines will work better for you in treating heart failure than somebody else. And so there's a lot of genetic testing going on, seeing about sort of personalized medicine, and is beta blocker 1 versus beta blocker 2 the right one for you. Stem cell replacement in heart is something that I've been interested in for 20 years. My hopes is we can stop having to do heart transplants because we could take a stem cell and inject it into the heart and grow you a new heart. That really has stalled and still not been mainstream yet. The big thing is we can do the stem cells and we can harvest the stem cells, but it's actually transferring them to the heart, getting them to stay in the heart and survive and grow. That transport medium has been real hard. So that's still at least 5 to 10 years away. Same with gene replacement. I would say one area that really has improved significantly even during my 20 to 25 year career as a cardiologist is these mechanical hearts. They've gone from huge refrigerator size equipment that the bearings and the things in them broke within a month to now small things that can be in your hand that can last 3 to 5 years. So in summary, I'd like to reinforce that heart failure is when the heart's not strong enough to pump blood to meet the metabolic needs of the body. And as you can see there on that slide, there are probably 40 to 60 things that can cause that. It's a common and expensive cardiac problem. 1 in 5 people in the United States will develop heart failure in their lifetime. Symptoms are many and vague, but probably the most common are shortness of breath, swelling, and fatigue. The echocardiogram that I showed you, the ultrasound, is probably the most important test to confirm or rule out congestive heart failure. And the good news is it's not an irreversible, deadly disease like it used to be 30, 40 years ago. There are people that when they get diagnosed with heart failure, Google heart failure, and they bring up an old study from 1987, which scares them silly. And what I say is that was 1987. This is a different ballgame going on now. The medicines we have, really since the early 1990s, there are many medicines and pacemakers that have developed that can make this a very chronic, treatable disease, and actually the heart can get stronger versus breaking your spinal cord and unfortunately being paralyzed. The heart actually can grow back, and it can grow back from pumping at 20% back up to 60%. Early detection of heart failure is important and portends to the best chance of recovery and getting on those medicines early before there's sort of permanent damage to the heart. And lastly, if one does have heart failure, we talked about there are many lifestyle modifications that are necessary to do well. Moderate exercise, salt and water restrictions, unfortunately adherence to a complex polypharmacy, which could be 47 different pills a day. You got to stop smoking, and you got to keep up with your vaccines. And then lastly, if your community is fortunate to have a heart failure clinic like we do here in Boulder, trying to get in with them, at least for a one-time consult, if not to be followed, has been shown to be quite helpful. Thank you, and again, thank you for tuning in tonight, and I wish you all a good evening.
Thank you so much, Dr. Blois. We're just going to give our listeners a moment to catch up and wait for some of the questions to come in. Okay, we have our first question. I occasionally, for no reason, while lying down, have a very vigorous, rapid, scary heart thumping, which lasts about half an hour to an hour. I've had EKG tests, and nothing shows up. What's going on?
Well, the question, a patient is having a fast heart rate that can last for up to a half an hour. That's a little bit different than our topic of congestive heart failure, and the question is what could be going on. The answer is, unfortunately, there are a lot of different things going on. There's 20 different types of arrhythmias. I think in a person like that, depending on how frequently it's happening, the best thing is we have ways of monitoring your heart rate at home with Holter monitors. If somebody's having these palpitations or heart racing on a daily basis, usually we can put a Holter monitor on for about 24 hours and try to see exactly what's going on. We can do a 48-hour Holter, we could do a 2-week Holter, and we actually have what are called implantable Holters, which look about the size of a paperclip, and you can put underneath your skin, and they have a battery life of about 2 years. Sometimes we find that there's no arrhythmias going on, and this is more related to anxiousness or something not going on in the heart. But I think on this kind of person, an EKG, an echo to make sure the heart's strong, and a Holter monitor would be what I would do, telling her exactly what's going on, or him. It would be a guess, because there are probably 20 or 30 different types of arrhythmias that could be.
How important is anti-cholesterol medication?
So the question is, how important is anti-cholesterol medicine, which is probably the one we're most common with are called statins. I'm a big believer in anti-cholesterol medicine, especially if you have coronary disease, have had a heart attack. They looked at the expected number of heart attacks that were going to happen as the baby boomers in America aged, and it was supposed to go up very fast. And actually the number of heart attacks has stayed flat. And the overall thought is probably it's from people taking statins. And the people that invented statins have already won the Nobel Prize of Medicine. Statins are not risk-free. They've got side effects. About 1 in 100 people who take it, it can cause inflammation of your liver. About 1 in 250 people, it can cause inflammation of your muscles, make you feel like you have the flu. But in general, especially if you have significantly high cholesterol, or you've had a heart cath showing you've got plaque forming in your heart arteries, and especially if you've had a heart attack and a stent or a bypass, I think it's a very important medicine you talk to your doctors about being on.
What is grade 2 diastolic heart failure?
So that's a good question. And the question is diastolic dysfunction versus heart failure. Many people, when you get an echo, they'll talk about the diastolic function of your heart. And that's basically how well your heart relaxes. And we know, unfortunately, everybody, as you get older, your heart gets a little stiffer, just like your blood vessels do. High blood pressure is more common as you get into your 70s and 80s and 90s because the blood vessels are stiffer. Your heart is stiffer. So if you get an echo, we might talk about that the diastolic relaxation is abnormal. It's called diastolic dysfunction. And there's 3 grades, sort of like the New York Heart Association, 1, 2, 3, 4, and 4 is the worst. So class 2 diastolic dysfunction is moderate stiffening and not ability to relax in your heart. Sometimes that equals heart failure, sometimes it doesn't. So if you have diastolic dysfunction on an echo, it means your heart doesn't relax well. It does not mean you have heart failure.
Anti-cholesterol medication versus diet and exercise instead of both.
There's another question on cholesterol management with medicines versus, and I think it's both. To take a statin and say you can eat anything you want is putting your head in the sand. But that said, there definitely is a familial genetic part to high cholesterol. And it involves enzymes in your liver. Your liver is the main organ that metabolizes cholesterol. Some people have a genetic problem with enzymes in the liver metabolizing cholesterol. So they can go on the most Puritan, healthy, low meat, low cholesterol diet and still have cholesterol levels about 200 to 250. So I think it's a combination of both. It is healthy eating. Everybody should be doing that. But unfortunately, there is a genetic component, and people who have that, statins are going to be helpful.
I have reduced kidney function as well as some congestive heart failure. How dangerous are diuretics for me? I do have swelling in my feet most of the time.
So this is a listener, participant who has both weakening of the heart, but also weakening of kidney function. And they ask, taking diuretics, which have to be watched closely or they can make the kidneys get worse. They're asking, is it safe to use diuretics if you've got both heart failure and kidney weakening? And the answer is yes, we do use diuretics in those people, but we're watching it closely. And we're doing blood tests called a metabolic panel to see what your creatinine is. But we know that if you are swollen and full of 15 to 20 pounds of water, your heart doesn't work well and your kidneys don't work well. So yes, you can be on a diuretic, but it needs to be watched very closely if you have kidney weakening.
To what extent can ejection fraction be improved by exercise/drugs?
So the question is, can you improve your ejection fraction, which we said yes, and how much does good exercise, aerobic exercise do that versus medicines? And the interesting thing is, and so the ejection fraction is the percentage of blood that is pumped out of your left ventricle on each heartbeat. A normal ejection fraction for somebody who doesn't have any heart problems, in particular congestive heart failure, is around 50 to 70%. Nobody's heart pumps 100% of the blood out. So if you're really below 45 or 50%, that's considered weakened. And when they've done studies to look at it, if you take a beta blocker or an ACE inhibitor, your ejection fraction can go up 10 or 15 points. With exercise, it hasn't been that much of an improvement. So I would say if you're really just looking at how is my ejection fraction going to get better, medicines do better than exercise. But exercise really helps in so many ways that aren't just measured in ejection fraction. that I think they're both important. But if you said, I have a heart that's pumping at 30%, I'm not going to take any medicines, but I'm going to exercise a lot, the study would say it might get up to 35, 36, but it's not going to normalize. You need to block those hormones that are activated in your body, and that's with medicines like beta blockers and ACE inhibitors.
What is your view of heart scans? I've had a heart scan with a calcium score of 0. I am 62, fit, but feel fatigued and also have palpitations, especially at night.
So we're sort of jumping away from heart failure here and talking about heart scans now, but there is something called an electron beam CAT scan, which is basically a CAT scan that they do a quick CAT scan through your heart. And we know that if you have cholesterol forming in your heart arteries, that cholesterol will come out as little speckles of calcium on the scan. So the best score to have would be 0, which is really consistent with no cholesterol in any of the arteries in your heart. As you develop cholesterol, you have more calcium. It is a test that's used by doctors to see if you have cholesterol forming in the heart. And the benefits are it can alert somebody who maybe didn't think they had cholesterol problems in the heart and help. I use it on people who, for example, are in their 50s or 40s or 60s, who maybe smoke, who maybe don't take care of their diabetes as well as they should. And to get this scan is a real reality check. All of a sudden you see you have cholesterol forming in your heart arteries. It becomes a motivation to take care of your diabetes better, to lose weight, to stop cigarettes. The downsides of the scan is it's radiation to your chest. And there are studies that if you have more than 2 or 3 of them, it raises the risk of breast cancer or lung cancer. That comes out from when they used to have these executive wellness physicals where the CEO of a big Fortune 5 company would get one of these yearly for a while. Unfortunately, radiation, there's side effects with that. So it's a good test. It's a completely different, longer conversation than just a 30-second answer that really is a whole lecture in itself.
Can metoprolol make you tired? Is arrhythmia dangerous?
So the question is metoprolol, which is one of the 2 beta blockers that I mentioned. Can it make you tired and are arrhythmias dangerous? And one of the side effects of metoprolol is fatigue. So yes, metoprolol can cause fatigue, especially in a younger person. But actually, what we do a lot in the heart failure clinic is you get started on metoprolol and you don't feel well for a while. And a while could be a couple weeks. Your body is turned on these hormones to sort of flog this injured horse to keep running. And we're sort of taking away those crutches. And the heart has to beat on its own. So people will say they get tired and fatigued. And then after about 2 weeks, we're already starting to see the heart getting better. And then they say, yeah, I got back to what I was, and then even better. So unfortunately, metoprolol and beta blockers get a bad name for causing fatigue. But in heart failure, as I pointed out, by taking that pill, you reduce your chance by about 35% of dying. Arrhythmias can be dangerous, which is the second thing, and there's a lot of different arrhythmias, so it's hard to say which, but if you have arrhythmias, you should get it checked out.
Do preventricular contractions affect heart failure?
So the question is PVCs, or premature ventricular contractions. Do they cause heart failure? And the answer is rarely. Almost everybody has skipped heartbeats. Your heart sort of beats lub-dub, lub-dub, and the dub is the ventricle. And so a PVC is lub-dub, lub-dub, dub. And it sort of skips. If you actually put a Holter monitor on a volunteer, everybody has a certain amount of PVCs during a typical day, usually about 50 to 100. So what we do know is that if you have a lot of PVCs, like 20,000, it's interrupting the function of the heart so much that that can cause heart failure. So it's really only that very rare person who has 20 to 25,000 PVCs, where pretty much every other beat is a PVC that causes heart failure. Otherwise, it's a very well-tolerated symptom.
So Does a diagnosis of SVT affect your eventual likelihood of getting heart failure?
So another arrhythmia is called SVT, or supraventricular tachycardia, which is when you have some extra electrical tissue in the top chambers of the heart. And the question is, can it cause heart failure? And the answer is, whether it's SVT or PVCs or atrial fibrillation, in general, they will not cause heart failure. But if your heart is beating at 120 beats per minute for most of the day, it poops out the heart and it causes heart failure. So SVT, really, really constant, and constant being like 20 out of the 24 hours in a day. But if you have little runs of 10 beats of SVT, that shouldn't cause heart failure.
And are you currently accepting new patients?
Yes. We, for a while, felt with the COVID that it was probably safe for people to stay home. I think it's still is safer at home, but our clinics are open, and I have available to see people, both general cardiology and congestive heart failure.
Okay. And we've come to the end of our time, so thank you for joining us tonight, and thank you, Dr. Blois. A recording of tonight's lecture will be available at bch.org/livestream in about a week. You will receive a post-lecture survey by email, and please take a minute to fill this out. Thanks again, and have a great night. Thank you again, Dr. Blois.
Good night. Thanks, everyone.